Hey, how you doing?
Hi, how are you doing? Sorry about the confusion this morning.
Your audio's off. You gotta turn your audio on. Just click on the icon in the far left of the Zoom panel. At the
Yeah,
far
I
left.
did. So my audio says it's
You can
on.
hear me, right?
I can hear you. Yes.
Hello, you can hear me, right?
I can hear you.
Okay.
Yes.
Okay, in the bottom panel, the far left, it has audio on the Zoom. Oh, there you go. Can you hear now?
No, I can hear you, but can you hear
Hello?
me?
Hold on.
My audio is on.
Yeah, you gotta turn it on.
It is on.
There you go. Can you hear?
I can hear you. Yes.
What's wrong? I don't know what's wrong with your system. Um, can you go to YouTube and see if you hear the audio on YouTube? Because
Okay.
I see your camera hooked up, but it's not working. So see if you can play a YouTube video and then tell me if you hear the music.
Okay. So can you hear me?
Hey, YouTube video.
Yeah, I'm playing the YouTube video.
Hold on. Let me,
I'm playing the video, but I don't know if I can hear myself. Okay. So can you hear me? Video. Yeah, I'm playing the YouTube video. I'm playing the video, but I. So I think there is some delay.
okay. Still no, you can hear me and I see you're connected. Maybe it's me. Hold on. Testing one, two, testing one, two, testing one, two. Testing one, two, testing one, two. Can you hear me now?
Yes,
No?
I can hear you.
Testing one, two, testing one, two, testing one, two. Okay. But you can't hear, huh? Yeah, according to the panel, it's connected, but I'm not receiving a signal. Do you see where but you have it turned on. The funny thing is, you know what, Farhan? Why don't we, yeah, it's turned on. I don't know. Why don't you reboot, leave the computer completely and come back in, okay?
Okay.
Oh, I heard you there. I heard
Did
you.
you hear me?
Hello? Yeah, I can hear you now.
Oh, okay. Well, I guess it magically worked.
All right. I don't know what I'm doing. I just bump around. That's all.
Yeah, it's just, sometimes these things backfire, but it is what it is. Let me just share my slides with you, and then I think we have about 6, 7 minutes, and then
Yeah,
we'll
we have
start.
a few minutes.
Yeah.
You want to test your slides or?
Yeah.
Okay, yeah. Well, I haven't started the webcast yet because we televise it on YouTube. That's where most people watch it from.
Yeah, I've seen a lot of your other videos. It's impressive work that you're doing.
I love it. And
Yes.
I'd be glad to broadcast in Urdu or Hindi.
Yeah, I would definitely do it. I think
Well,
maybe,
because I think there's a need, don't you think? There's a need?
yeah, absolutely. I actually do a lot of global neurosurgery, and I go to different places, including Kenya and Pakistan. Of course, I'm originally from Pakistan, so I go there frequently. Um,
Oh,
and
okay.
in fact, which reminds me, we're going to do a skull-based symposium in Pakistan in April. So maybe we could do at least a couple of those talks live. Uh,
Yeah,
some
we
big
could
names are
we could
going with me.
televise it. We can televise the whole thing.
That would be awesome.
Well,
I think,
we'll talk later, but you can send me the info. I'll
yeah,
look it over.
yeah,
Uh, of course, I have to charge, but it won't be much,
yeah,
and it'll be well worth it because
yeah, definitely.
it'll be spread the word further.
Yes, yes, absolutely.
I mean, it's wonderful you have a great video, but if you can't spread it, it's not
Yeah,
worth
I
much.
know. I agree. I totally agree. All right. So can you, what, are you seeing my
Yeah, that's
presenter
perfect.
slide?
Yeah, that's perfect.
Okay.
Do you have any videos or anything?
I have videos. I have a lot of videos. I'm a video guy.
Okay, let's test them. Let's test the video. Because we're gonna make, do you have any sound on the video?
No, there's no sound. They're all
Okay, okay.
my own
Well, let's
edited
make
videos.
sure we got it hooked up okay, and I can hear it. Just play one of the videos. Make sure it works.
Do you see it?
Yeah, it's working.
All
Wanna
right.
try the other ones? Yeah, excellent. Good video.
All right. Good.
Okay, are we waiting for any panelists at all, or do you know?
I don't, I think one of the guys was going to join as a panelist, but he was probably in the OR. It was a
Oh,
kind of
okay.
short
Well,
notice.
no, don't bother
But
them.
that's okay. Next time when we do it, if we do it next time, I will have, we'll have a good group of panelists.
Okay, we'll start. Well, people will join along the way.
Okay.
But I just wanted to maintain contact with you to try to get things going because I see you're active as a director of a residency program. So, I mean, you obviously have influence on education
Yeah.
in a good way.
Yeah.
So we'll just start. Okay, could you stop screen sharing so I can introduce your whole face? There you go. Okay. 10, 9, hold on. Hold on. Okay. Just give me 1 minute. Yeah, I've got to hook it up to YouTube. Uh, just 1 second. Okay, we're on YouTube. We get back on Zoom. Okay, we do have a panelist. Okay, I'm sure I'll have the panelists come in. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, good evening. This is
Good
Dr.
evening.
John Bennett broadcasting from Miami Beach here in the background. We have the pleasure of having Farhan Siddiq, a patient neurosurgeon that he's from the University of Missouri. He's a director of the residency program education there. And we were talking, he also broadcasts, potentially can broadcast in Urdu, a language which most people haven't heard of in this country, but it's a language that's spoken in that part of the world, as well as Hindi, which is a significant population in India. So I welcome Farhan, it's all yours.
Thank you. Thank you for giving me the opportunity to speak. I think I follow your forum. I follow your videos. There's a lot of very informational stuff, and I frequently see one of your videos. So thank you for inviting me to this talk. I know it's the afternoon and everybody's a little bit busy, so I'm going to try to go quickly through this talk. I have several other talks that offshoot from this that we can maybe at some point go a little bit more into details for. I am a cerebrovascular neurosurgeon. I do a lot of open vascular surgery and endovascular as well. But of course, from the perspective of neurosurgical residents, most of my talks are focused on open vascular surgery. So that's what I'm going to share some of those with you today. Let me just share my slides. So the topic that I'm discussing today is kind of my evolution for open cerebrovascular neurosurgery over the last 10, 15 years of how, I started my career after my training, and then how I slowly continued to evolve into becoming more and more minimally invasive cerebrovascular neurosurgeon, and some of my own thoughts and ideas that I want to convey to you as to why I think this is important. So my topic today is supraorbital craniotomy for anterior circulation aneurysms. The slides are a little stuck. So I have to, as part of University of Missouri, I have to announce my disclosures. So these are my disclosures, although I've never seen a dime or penny from any one of them, but I still have to disclose them. So when we talk about anterior circulation or circle of Willis, this is kind of the picture that comes to mind. And anterior circulation in particular deals with aneurysms of internal carotid artery, ACOM, middle cerebral artery, and PCOM. Those are the most common aneurysms, and those are the aneurysms that we tend to treat through these minimally invasive approaches most of the time. And then the relevant brain anatomy also is very important, and it's obviously very different for each different site or location of the aneurysm. And the interesting part, for cerebrovascular neurosurgeons is that with every aneurysm and with every anatomy, there's a different relevant brain anatomy that we are encountering, and completely different strategies for treatment of these different location of aneurysms. So today, for the sake of timing for this talk, I'm going to mainly focus on PCOM aneurysms. I'll show you some examples and videos of PCOM, and then I'll focus on the middle cerebral artery aneurysms and show you some videos. I like history. It's very important for neurosurgeons to understand the history. But if you look at the history of neuroanatomy, the two individuals that come to mind, especially circle of Willis, is Christopher Wren. Sir Christopher Wren was an English. He was not a physician. He was actually an architect and used to draw a lot of illustrations for this gentleman, Thomas Willis, who actually was the first one that described circle of Willis. He actually also, for the first time, introduced the idea of neurology or neurosciences. So he's kind of pioneers of that. And this is one of the pictured illustrations from their time. This was the book that was published as Cerebral Anatomy or Anatomy. And even though he's an Englishman, but the book was in French, published in 1964. And then the first complete picture in that book was from that time frame. And if you look at it, it's not very different from what we know today. Dr. Willis is also responsible for naming the cranial nerves the first time. So I think that also credit goes to him. And also, when we talk about minimally invasive or supraorbital or keyhole craniotomies, we should not forget Axel Pernisky. Axel Pernisky introduced this idea and popularized it, and his seminal publication in 1998 of cerebrovascular disease treatment is really pioneer for his time. And he was the first one to introduce this idea. Before that, and even up to now, majority of neurosurgeons still treat brain aneurysms with open terional or sometimes orbitozygomatic type of approaches. But this was the first time that a neurosurgeon was able to introduce this idea that we can treat majority of these aneurysms, if not all, through minimally invasive approach. And in this paper, I mean, it's a pretty extensive and a very good paper, and they reported 179 aneurysms, and in all locations of anterior circulation. This is Axel Pernisky, and this is a picture that comes from his original paper. And I think the way we practice supraorbital craniotomy is pretty close to what he had actually published back in the day. So my stepwise approach to understanding supraorbital craniotomy for aneurysm clipping and how I learned it over the last 5 to 7 years, I would like to go through with that. But a lot of that learning comes through cadaver dissection and learning through the cadaver, and then applying the same knowledge back and forth to live clinical scenarios. So the first important thing for supraorbital is identifying surface landmarks and incision planning. So the first surface landmark is obviously supraorbital notch. It's a supraorbital craniotomy, so pretty similar in name. This is a typical incision that I plan out. I plan out the supraorbital nerve, which is my medial most landmark. 99% of the time, if I keep that as my medial most landmark, I usually never end up into the frontal sinuses, which is one of the issues that can sometimes happen, although easily manageable, but you have to know beforehand. So I mark that out, and then I mark out the superior temporal line. And when I originally started, I was making incision actually in the eyebrow. A lot of times, commonly, this surgery also is known as eyebrow surgery. But as time goes on, my incision has slightly now gone just a little a line above the eyebrow. I think that heals a little bit better. Incisions through the eyebrow, sometimes the hair grow in a very random fashion, and sometimes that could be an issue. I haven't had anybody come back and complain to me, but that's one of the common things that when I talk to plastic surgeons, they talk about. So I keep that in mind. And if you look at it on the lateral aspect, I don't know if you can see my mouse, but on the lateral aspect, there's a little bit of that lazy S-shaped swing that goes over, towards the lateral canthus. The purpose of that is to avoid the frontal branch of the facial nerve, so that we can, and we'll go into a little bit more into the anatomy of that and how to avoid it in more detail. So the layers here are slightly different than typical craniotomy that we do in other locations. So there's obviously skin, then there is subcutaneous tissue or fatty layer. There's a muscular eponeurotic layer, which is the frontalis muscle that causes this, raising of the eyebrows or folds in the forehead, which is very important since this surgery is aimed at cosmetic results. So we have to be very careful about all of those layers. And then underneath that is a fourth layer, which is a loose areolar layer. This is sort of the subgaleal layer. There's no true galea in this location, although we still call the aponeurosis or consider that as the extension of galea, but there's no true galea in this position. The subgaleal layer is important because that's the layer I use to dissect under the scalp to get more retraction, so we can expand our craniotomy and surgical corridor. And then the last layer is pericranium, of course. So here in a cadaver model, we're going to go through all of these layers. This is incision using 15 blade through the skin and go through the subdermal layer. And immediately as you open the subdermal layer, there's a the muscular eponeurosis or frontalis muscle layer. So once you cut that, there is the loose areolar tissue. This is the layer where you can easily do blunt dissection through any instrument, even with a finger. and use that to increase your exposure. Once you do that, and within this same layer, I go medially towards the supraorbital notch area and use that to find supraorbital nerve. And if I need more retraction, I can actually dissect around the supraorbital nerve and get more mobilization. Here in this picture, immediately you can see the supraorbital nerve. My incision actually goes over the supraorbital nerve. I don't cut the supraorbital nerve, but I use either high magnification or under the microscope, find it and then dissect it so I can mobilize it. And then the pericranium. In the earlier phases of my learning, I used to bring this pericranium down all the way to the edge of the orbit. But I've stopped doing that. Sometimes when you do that, patients wake up with a swollen eye. It doesn't cause any problems, but of course, and it goes away after 4 to 5 days. But if you don't do it, you can avoid this swollen eye or a bruise around the eyelid area. So remember the pericranium laterally goes all the way up to the superior temporal line. So you can use your finger, feel the superior temporal line, and then cut the periosteum in sort of a semi-D-shaped fashion, pull it downwards, and then you can feel that the fascial layer of the temporalis muscle. Then you make an incision in the temporalis muscle, and the temporalis muscle goes down. This is a cadaver model, so I'm not using my typical retractors. I'm using sutures to retract, but you can get essentially the same amount of exposure with that approach as well. So you're not really dependent on any fancy retractors if you don't have them. So the next step is making a burr hole. And when we go to the craniotomy part again, once again, I'll review the anatomic landmarks that we have to remember. So first landmark, like we talked about, supraorbital notch, supraorbital nerve. You find it, mobilize the scalp around it. That gives you enough retraction to have appropriate size craniotomy. And then finding the keyhole all the way anteriorly, and then use that to make about 4 millimeter burr hole. I usually try to leave about 2 millimeter space between the burr hole and the superior temporal line. That allows us to place a craniotomy plate and helps with the atrophy later down the line that may become prominent. Again, emphasis on the cosmesis. Then the next step is to plan a D-shaped craniotomy. The measurements are about 3 millimeter in length and about 2 millimeter, 1.8 to 2 millimeter in height. Centimeter in height. And then the last step is to flatten all the edges so that we can have a wider panoramic view. It also is very important for instrument handling and maneuvering, especially when you're clipping aneurysms. The clip applicator has to go in, and sometimes with deep locations, it could become a little bit of a hindrance. So beveling those edges improves your maneuverability and ability to approach cerebrovascular lesions. Here in a cadaver model, we have a burr hole. You can see the dura. Notice the distance between the burr hole and the superior temporal line. If you come very close to superior temporal line, sometimes it's hard to place the plate, and the craniotomy is very, very small, and it makes it a little bit challenging to reapproximate. So the next step, you take a router or a drill bit and make the craniotomy. When I'm doing the craniotomy, I intentionally angle my router so I bevel those edges on the way, and then I use a second drill bit if I need to bevel them a little bit more. And the idea is to create a cone-shaped craniotomy. We'll go over that idea again in a few minutes. So here's a typical craniotomy completed. This is obviously a cadaver model. It's about 3 centimeter long and approximately 2 centimeter in height. And then once all the edges are beveled, the dura is cut in a D-shaped fashion, reflected downwards. Medially, once again, you can see the supraorbital nerve, and then you see the anterolateral surface of the frontal lobe. So it's a pretty small view, and a lot of people will feel that it's daunting to consider aneurysm clipping through this view. But I'll tell you that it's with some experience and practice, you can actually get there very easily. One other important thing that we mentioned earlier is the frontal branch of the facial nerve. So why is it important? Of course, it's important in any craniotomies where we're going very anterior in the skull base. Just remember, for more traditional craniotomies, when we do zygomatic craniotomies or terional craniotomies, when we go anteriorly, we stop at that fat pad of the temporalis muscle and then go interfascial and leave the upper fascial layer, which houses this frontal branch of the facial nerve, and we pull all the craniotomy flap, myofascial flap forward. The purpose of that, all of that, is to protect that nerve, because if the nerve is injured, the forehead becomes flat, and it becomes very obvious in patients, and of course, patients don't like it. So now we're doing supraorbital. Just keep the same anatomy in mind, but now we're approaching actually anterior to the frontal branch. So how do we preserve it in those scenarios, and what is the concept of that? So there's been some studies done. This is one of the papers published by Dr. Lawton Group actually recently, in which they studied several cadaver models to look at all the branches of the frontal branches of the facial nerve and their anatomy. And if you look at it and their final conclusion, there is an area, semicircular area of about 1 centimeter radius from the lateral canthus, where the likelihood of finding the facial nerve is extremely low. And then this safe zone can be extended posteriorly and inferiorly below the orbitomeatal line by about 15 millimeter. I'm going to go back to the picture. So keep that picture in mind when we're doing the supraorbital craniotomy. Remember when I said that my incision just outside the lateral margin of the orbit goes a little bit inferiorly, and the goal for that is to prevent injury to this frontal branch. And then the second maneuver that I do is immediately as I get to the loose areolar tissue below the frontalis aponeurosis, I do this blunt dissection, and by doing that, the nerve actually dissects away from our craniotomy, and then the retractors pull the nerve backwards. So it's the same concept when the OZ craniotomy or pterional craniotomy, where we're pulling the nerve forward along with the fascia. Here, along with the fascia, we're pulling the nerve backwards because the craniotomy is more anterior. So this is one of my patients. Of course, all of the pictures from the patients are presented here after obtaining consents from those patients, which is standard policy of our medical school and university. So this is one of the patients. All the identities are obviously not revealed. So this is one of the patients where we did supraorbital craniotomy. Again, you can see the cadaver model in the life is almost pretty much similar. The only difference is the retractors here are fish hooks, and I use the standard retraction system that comes with any other craniotomy. This is a typical craniotomy, and then the opening in for the craniotomy is about 3 by 2 centimeters. So the question is, can we get a panoramic view to a cerebrovascular network? And I'll submit to you that yes, we can. And this idea was originally, again, presented by Pernesky. And if you look at his original paper, in that paper, they talked about beveling those bony edges to make them flat. So they talk about mostly the lower portion where you try to make it flat to open up the panoramic view. But I feel that that's the same approach that you can do actually in the entire periphery of the craniotomy to increase your exposure. And we have some studies to show you. I'll show you some data, which is preliminary data. It's not final and it's not published yet, but hopefully we will continue to work on it in our lab and publish that soon. So there are other authors have presented different other ideas for opening that or making that cone area or the exposure bigger. This is a paper published by Dr. Zuccarello's group about a decade ago. And so in this paper, the idea is that along with the supraorbital, they perform orbitotomy where they take out the supraorbital ridge. So this is kind of more transorbital approach rather than a supraorbital, and then extend that bony removal to the greater wing of sphenoid, and then get a larger view. So I think this is a great or neat idea. However, I think in my experience or my view, it creates a little bit of an opportunity for maybe not as great cosmetic result. Plus, I think in most instances, I don't think that we need that big of a craniotomy. So I usually reserve that type of craniotomy for if, for instance, I'm clipping a very high riding ACOM where I need to have more upward exposure, but that's not my general practice. But it's important to know different ways through which you can increase or improve your exposure for this type of minimally invasive craniotomy. So based on all of this knowledge, we came up with a hypothesis that if we under-drill the craniotomy edges, and if we drill the greater wing of sphenoid, then even through a supraorbital keyhole craniotomy, we can actually improve our view. So we plan to have 5 cadaver heads and do 10 supraorbital craniotomies. And in phase 1, our plan was, this study is still in progress. We have some preliminary results, but we will have more results later. So in phase 1, we would do a navigation scan and plan out the initial supraorbital craniotomy. We will go ahead and dissect just like a typical aneurysm surgery, dissect the optic nerve, sylvian fissure, and then expose the middle cerebral artery all the way up to the bifurcation, and then we will expose at least 5 millimeters of distal M2s, which is kind of what most surgeons would consider an appropriate exposure for an MCA aneurysm. Clipping, and then we will do the same for the ICA terminus and the ACOM location, and then also expose more of the superior temporal surface. In the phase 2, we will do more bony resection by flattening the craniotomy edges and resection of the greater wing of sphenoid, and then repeat the navigation scan, and then plot out all of those markers to see, once again, how much of that exposure we are able to obtain. So here's one of the cadaver models where we have dissected, through a same standard supraorbital craniotomy. We have dissected the dura, elevated that dura over the greater wing of sphenoid, and then tried to approach lateral part of that orbital fissure all the way medial. In fact, if we continue our dissection or bony removal, we can go all the way up to the clinoid process. Of course, for clinoidectomy, this is, the approach is a little bit challenging because it's more flat and you don't see a lot of clinoid through this approach. But certainly with this extra resection of the greater wing of sphenoid, you will have a better access to clinoid. And I think hopefully at some point we will publish our studies or results of our studies soon. So once you do that, you can actually see all the way to the anterior sylvian drainage vessels. Here you can see those drainage vein. I've cut the dura, and what we're looking at, if you do a caterional craniotomy, when you come out from the lateral side, you're looking at the meningo-orbital fold. But here now we're looking at the same fold, but from above, from the top. So the anatomy, just keeping in mind, is slightly different. So you can go all the way to the sphenoparietal sinus and sphenoparietal drainage. And here's some of our data through the navigation scan. If we make the apex of the craniotomy at the top and look at the overall exposure, once you do that extra bony dissection, as you can see, you can enhance your exposure significantly in the actual surgical bed. And if you do that, you can actually expose all the way up to, this is the view of the optic nerve, ICA. You can see the third nerve here, and you can actually even look at the entire temporal lobe. Here we have actually done a selective amygdalohypocampectomy, and by doing that, we are able to expose the optic nerve. Of course, this is a cadaver model. That's not a surgery that we typically do, but just to show you that even for epilepsy surgeries, they could be done supraorbitally through this approach by resecting that extra part of the bone that's overhanging on the anterior temporal aspect. And if you continue to dissect, you can now plot out the entire course of the third nerve. Here you can see the posterior clinoid, and just behind the posterior clinoid, that small part of the basilar artery, the posterior cerebral artery, and the branches of the PCA are also visible through this. So you can get a pretty good panoramic view of all the deep circulation. So let's start with some of the aneurysms. That's what we're here for. That's what we love to see. So let's start with some of the aneurysms. So I'm gonna start off with the PCOM. Like I said, in the interest of time, I'm going to limit today's talk to mostly PCOMs and MCAs, and then ACOMs. They have a lot of there's a lot of detail about ACOM aneurysms that probably I'll leave that for some different other time. And then other aneurysms such as ICA terminus, which is not a very common aneurysm, but we certainly can treat through this approach as well. So this is a patient, a 53-year-old that presented with grade 1 subarachnoid hemorrhage, presented about 1 week after the onset. The angiogram showed this aneurysm here, and it was very unusual anatomy. It looked like a fenestrated aneurysm. we had a discussion about endovascular approach versus surgical approach because the patient was young, and we felt that because of the neck fenestrated appearance, which we later found out was just a large anterior choroidal vessel, but at least on the angiogram, it was hard to figure that out. But I'll show you the video, and I'll show you the versatility of this approach through which you can see complete anatomy and be able to dissect. So here's our typical supraorbital craniotomy. Typically for PCOMs, you do just a little bit of medial horizontal Sylvian fissure dissection in that horizontal part. I don't open the entire Sylvian fissure, but here we're looking at the aneurysm, and because it's kind of a late rupture aneurysm, there is a lot of adhesions. Anatomy is not very clear, but you can see there's a lot of room. This is, people who've done a lot of PCOM aneurysm clipping will be able to appreciate that you don't need more room than that. And then here we have the neck isolated, and that large vessel which appeared to be a fenestration, which was actually a large anterior choroidal. So once we identified the neck, I placed a sidewinding clip, and now you can see this large anterior choroidal vessel, which is separate. I felt that the clip was not all the way across, and I wanted to maneuver it a little bit more. And I can see a small PCOM also. And then so I advanced the clip. Now, as we understand, with PCOM, the limiting factor of clip advancement is that posterior clinoid, because the clip prongs end up invariably hitting the posterior clinoid. So I usually use this sidewinder clip for PCOM so that I can slip around the posterior clinoid. Here, you can see now the aneurysm is completely clipped. You can see a little tiny perforator like PCOM. Let me go back into that picture and hold it for a second. And here, you can see that white thing, that's the posterior clinoid. It's a very safe area. There's really nothing important around that area. The important structure, which is the third nerve, is more anteriorly placed, and we've already obviously excluded that from our dissection. So final clip, final examination of the neck, everything looks good. Post-operative angiogram looks great. You can see that large anterior choroidal now more visible and more appreciable. Let's go to the next case. Well, this is sure why I did that. Okay, so this is a patient with a large PCOM aneurysm with a fetal PCOM or fetal communicating artery. So once again, this was, he's a young guy, a 51-year-old. Some would argue that this could be coiled, and I agree. I think this aneurysm could be coiled. The concerning part here was a little bit of this neck part, which looked like there was a neck, and then the aneurysm, and then the PCOM. Again, like I said, a lot of people in this the type of aneurysm would choose to coil this aneurysm. We had a long discussion with the patient and talked about, a potential endovascular approach versus surgical approach. And when you have a heart-to-heart discussion with a lot of patients with both minimally invasive approaches and the fact that endovascular approaches sometimes require long follow-ups, most of the patients who are in younger age group tend to choose surgery because they don't like to have more or long-term follow-ups and potential for subsequent treatments. Although as endovascular approaches are becoming more and more common, I think, and safer, I think that fear or apprehension is also slowly going away. However, nonetheless, in this case, we did decide to do surgical clipping of this aneurysm. Again, same approach. I'll skip the craniotomy part and just go to the main portion here. Release the CSF initially from the optic cisterns, and then start with the Sylvian fissure dissection. You can see some of the fresh subarachnoid blood in the Sylvian fissure. I only for PCOMs dissect the medial part of the Sylvian fissure, and then go over to the PCOM, and then you skip over, go to the third nerve. You can see the little edge of the tent there around the third nerve, and that's the area where I like to dissect and identify the fetal PCOM origin. And just under the sucker, you can see the original PCOM. And then once that's exposed, then we start doing more dissection to expose other relevant anatomy, expose the neck. I like to be minimalistic in my dissection of the aneurysms. I don't like to expose the entire dome. I don't like to expose. It's just the way I am. But here you can see that we have after some dissection, we are able to separate the anterior choroidal, which is the other important and relevant anatomy. And again, another sidewinder clip that goes around and preserves that third nerve and without any manipulation of the third nerve. So in this case, I was not able to see PCOM, which is very common. Once you deploy the clip, the fetal PCOM is hard to find, but you can see almost always see it medially. So then you dissect between that keratoco-optic cistern, where you can see a lot of perforators. You have to be very careful with that dissection because there are a lot of small perforators coming. You don't want to injure any one of them because they're all important perforators. But you can see actually here, and we did micro Doppler as well to confirm that the PCOM was filling, and then ICG, and then subsequent angiogram shows that the PCOM is still filling and the aneurysm is completely treated. Here's the craniotomy. And this is what I was talking about when I leave a little bit of that 2 millimeter around the supraorbital, the superior temporal line. That's the area that I use to have this the burr hole cover plate, and I like to do that burr hole cover plate under this part of the temporalis muscle that we have pulled down, because invariably there is going to be some temporal atrophy. But when you put that plump plate, that allows for that atrophy to not become appreciable or visible. Because remember, once again, the purpose of the supraorbital is maintaining cosmesis. Here is another PCOM. This one was a small PCOM in a very young patient who has a very strong history of aneurysm ruptures. So I was following it for a while, and then at one follow-up, it appeared like there was some change in the anatomy, and we did a 3D, and you can see that the PCOM, it's very small, but it has developed a small bleb. So going into this, I didn't appreciate how proximal this PCOM was. And it's not very common for a PCOM that I have to drill the clinoid, but in this situation, we kind of got trapped. That was very proximal. So I'll show you what the anatomy of that looks like. So here we're dissecting, again, keratoco-optic region. I open up that medial part of the Sylvian fissure, a lot of sharp dissection. It's unruptured. It's a very pleasant dissection. So once you open that, you can see the ICA. We do the dissection of the keratoco-optic cistern, and then I start pulling the temporal lobe, and that's when I realize that the aneurysm is actually too proximal. So I do the dissection around the distal area. I try to pull it into our field, but it just wasn't very comfortable. So then at that point, I decided to do the clinodectomy. But here, I want to stop for a quick second just to show you how small that clinoid view was. So nowadays, this was earlier part of my career, but nowadays, if I have to do that, I will remove this upper part of the greater sphenoid wing, which I'm going to show you later how it improves your view of the clinoid. But this was earlier part, and I have earlier times in my initial experience with supraorbital craniotomies. But anyhow, so we did some coagulation of the dura, make an incision in the dura, pull the dura down, and then use the drill. Of course, very nerve-wracking because we don't have a great exposure. But now I realize that this proximal part of the bone could have easily been removed to gain more access to this part of the clinoid. So we did some drilling. Now we're drilling right on top of the aneurysm. The dura is, of course, protecting us, and that's how I like to do most of the clinodectomies. But at one point, I realized that I can't continue to drill anymore, so I used some kerosene, and I used the kerosene to remove both the bone as well as the dura around it. And once we remove that, the proximal view of, you can see in a second that proximal view of the PCOM and the fetal PCOM comes into view. Here you can start seeing that cleft for the first time. Now we can pull the aneurysm into the view, dissect around it. This one again is hard to see the origin of the fetal PCOM, so we do some more dissection around it, and then eventually we are able to see fetal PCOM going away. Then you focus back onto the distal part of the neck dissection to separate the anterior choroidal and make sure all those adhesions are gone. Here, a lot of adhesions, small aneurysm, but after a lot of dissection, we were able to expose the neck. Again, small aneurysm. So this one, just because of the anatomy and how it looked like, I had to clip with the left hand, which is not my dominant hand. There you can see that fetal PCOM. So I initially tried the clip, but I felt like the bone was still restricting my view. So I took the kerosene again and dissected some more bone. And it's very tailored removal of the clinoid. We didn't do the full clinodectomy, but just enough so that we can get the view and we can slip the clip prongs and get a complete occlusion of this aneurysm. Here, once again, now we can see the clips are going in easy, no obstruction, and then you slowly deploy the clip and treat that aneurysm. Every time you deploy the clip, you make sure that the prongs are all the way through. There's always one side that you can see way better than the other side. That's just kind of the nature of this surgery. And then you see the dome, do an ECG to confirm that the dome is completely collapsed. This is a post-operative angiogram the next day, which shows complete exclusion of the aneurysm. So let's go to the middle cerebral artery clipping. So I have a few cases. Now, a lot of times, when I talk to cerebrovascular surgeons, and me too, to be very frank, in the very beginning when I started doing supraorbitals, I wasn't very sure whether middle cerebral arteries could be clipped. But if you go back to the original source, this is Perniski's paper, and in his original paper, he had 48 middle cerebral artery aneurysms out of 179, which is a pretty decent number, and one of the most common ones that he clipped is a very standard, typical middle cerebral artery aneurysm, which is sort of in a category of medium to large aneurysms pointing downwards, and a significantly long M1 segment. He also clipped 2 contralateral ones. Of course, I've never done that, but certainly shows you the versatility of this approach in an experienced hand. So, initially when I was thinking about starting doing middle cerebral artery aneurysms, I started looking at literature, and I came across this paper which is a cadaver paper where they did anatomic studies to show how to dissect the sylvian fissure and to approach the middle cerebral artery bifurcation, and showed that was feasible in a cadaver model. But of course, cadaver studies, cadaver dissections are obviously always slightly different when you compare to live scenarios. Here's one paper published quite a while ago, actually. This is from India, and what they show is that for the MCA, because it's a little bit more lateralized projection, they go straight at the sylvian fissure and start dissecting the sylvian fissure, and are able to identify the frontal and the temporal branches and the M1 right away. So conceptually, yes, a great idea. I still tend to go all the way to the optic nerve and then come back and kind of go back and forth, actually. And I'll show you what the reasons for that are, because that helps me to pull or bring in almost the entire majority of a typical sylvian fissure. And I will submit to you that once you start doing that, you will realize that actually sylvian fissure dissection is much more pleasant when you're doing supraorbital, because you avoid all these big veins, all these crossing veins to the frontal lobe, which we invariably in a standard approach always end up coagulating and sacrificing. Here, there are usually none of those. There's typically one small branch, but I've never had any issues with those. But I can dissect pretty much all the veins and dissect them down inferiorly and pull them towards the temporal lobe. So here's our cadaver dissection. So the idea is you go down to the optic cistern or basal cisterns, release the CSF, and that helps that sylvian fissure to fall. Then you move your microscope and to look from inside out, and you can see the edge of the sylvian fissure. Still a very daunting view, because some would argue that it's very small space. But I'll tell you, as you continue to dissect and dissect more and more and find the distal M2 branches and then go more proximal, you can actually dissect the entire sylvian fissure and get a very, very good view and an open view of clipping, which is no different from a standard terional craniotomy in pretty much most cases. Now, again, I don't do giant MCA aneurysms or aneurysms that I think that I have to do a lot of fenestrated or fancy clipping strategies, or potentially that may require bypasses. Those I don't do through this approach. So this is for the medium to small size aneurysms up to, I would say probably up to 1 to 1.5 centimeter, not bigger than that. Here is a view of the sylvian fissure. You can dissect. So this is a cadaver. We go straight at the sylvian fissure. We dissect the sylvian fissure, and you can see the M1 and very nice view of the bifurcation. And then you can track it all the way medial. This is a left-sided approach. The previous one was a right-sided. Here you can see most likely looking like a trifurcation of the middle cerebral artery, and you can see the good view of the entire bifurcation. So assuming that there's an aneurysm, right now you have proximal control, you have distal control, you have pretty good view for any standard aneurysm clipping. So here's one of our patients where we are earlier I was talking about the dissection of the ciliary fissure. This was slightly older patient. I think she was in her late 60s. So ciliary fissure, you can see that temporal vein. I always pull that vein or move that vein towards the temporal side. And as you continue to dissect, there could be a small bridging vein, but it's usually very, very small. And as you open the ciliary fissure, the first thing I see is M2s. And so I know right away this is that small bridging vein that I usually sometimes find and coagulate and cut. But once you cut that one vein, all the other veins usually tend to just slide away from your view, and you never have to encounter them again. So all the next steps are geared towards exposing the vascular anatomy, and we're still at the M2s. We still haven't seen the bifurcation. So I kind of go back and forth. I try to do the initial arachnoidal dissection, and I think the video. Oh, so this is a second actually video of a different patient. Let me just go back. Yeah, this is the left side. This is another individual. As you can see, the Sylvian fissure, once you release CSF and apply some retraction, it just tends to open up almost by itself. And you keep opening it, and all of a sudden you get proximal control. And once you have proximal control, here you can see the anterior temporal artery. I see a bifurcation. Really, really beautiful view. You can do a full panoramic dissection. And then once you find the proximal, then you start going more lateral, and you can expose more lateral. And then at the end, you go to the aneurysm. So you get all your vascular view, which is safe beforehand. And then one trick that I do at the end, once the Sylvian fissure falls in view, let me stop that video here. I then make a little, if there is a little bit of a dura flopping into the field, I make a little more incision into the dura and put some more tack up sutures so that I can have a good view of that anterolateral aspect of the Sylvian fissure, so that I can clip the aneurysm successfully and have really good both proximal and distal view. And here in this picture, once I do that, you can see that the aneurysm sort of delivers into the view, and it becomes really very easy after that. Let's go to the next slide and see if I have another one. Well, sometimes the videos play again. So some of the anatomic considerations, looking at the literature, especially when you're talking about the middle cerebral artery aneurysm, supraorbital clipping, is the length of MCAs. A lot of people talk about that. Some authors have recommended 15 millimeter length is feasible for supraorbital, and anything more than 15 millimeters probably feasible for either mini pterional, standard pterional, or other approaches. And this was one of the papers published some years ago. And this paper particularly focused on the selection criteria based on M1 length. There are other authors that don't think that the length of M1 matters, as long as this is a MCA aneurysm and not an M2 aneurysm. All of them are anterior temporals, proximal M1s, M1 perforated aneurysms, and all the way up to the MCA bifurcation. They're all approachable regardless of the length of the M1 segment. And after a lot of experience, I sort of tend to agree with that. I think I still take into consideration the length of the middle cerebral artery, but I have a lot of other things that I consider, such as projection of the aneurysm, the actual location of the aneurysm, how close it is to the lateral cranial wall and the surface, and how much of that medial lateral exposure I would like to get for that particular patient. I do think as you continue to get more and more experience, you can manipulate pretty much all anatomies into the view and get safe clipping through supraorbital. But when you're starting off, obviously keep those anatomic considerations in mind. Some people have done. Some folks have argued about a transciliary approach, which I think is a great idea. A lot of people who do that approach usually involve oculoplastics for that particular exposure. I think the reconstruction is actually very great with that type of exposure. I typically tend to not do it because I don't have those services available most of the time. It probably lengthens the surgery, and I'm just a little not sure how much of proximal scalp retraction I can do, because I really like to get that height of the craniotomy all the way up to 2 centimeters, at least 1.8 to 2 centimeters. So that's why I've not ventured into it, but I think it's a very fine approach, and people who have experience or have ability, certainly consider that. Here is one patient that I treated, 54-year-old, new onset headaches, although not ruptured, but had a strong family history of ruptures and wanted to get this aneurysm treated. Very small aneurysm. Under normal circumstances, I probably would have not. But notice the length of the M1 is almost about 2 centimeters. So this is what we would consider normally a long segment M1. So let me start the video here, and I'm going to skip over some of this earlier part because we've seen that already. So when we get to the aneurysm, as you can see, this aneurysm is, and I'm going to come back to this video again because I did another trick in this video, which I'll talk about. You can see the aneurysm, although the aneurysm is visible, but I wasn't really entirely sure. So I did some more maneuvers. I will talk about it in a few minutes. And then once I did that, I was able to see the temporal M2, the frontal M2, and get a complete exposure of the aneurysm. And then after that, the clipping is an easy job.
Excuse me.
Did you say something, John? Okay. Once again, let's go back into how I approach those the MCA aneurysms, aggressive flattening of the corners, aggressive release of CSF. Here's a video of a patient who had mild hydrocephalus, and we were doing supraorbital craniotomy. As you can see, the brain is very plump and full. For the first few minutes, I regretted my decision, but then persisted because I didn't want to go back. But you just have to be gentle and keep going slowly until you get to the cisterns. And once you get to the cisterns, you can then release CSF. One thing I would also say is that keep in mind, you can do an EVD through this approach also. The trajectory is somewhat different, but it's no different than any other external ventricular drains. You can use ultrasound to place an EVD if there's concern for hydrocephalus or CSF release. But once you get to the basal cisterns and release CSF, the anatomy becomes very easy and approachable. So here's the optic nerve, and once you get there, the anatomy becomes much more manageable. One thing I also do for MCAs in particular, not for other aneurysms, once I release the CSF, I get a good basal cistern view, optic nerve, optic chiasm. I also go ahead and release the CSF from lamina terminalis just because I want the brain to shrink and I want the Sylvian fissure to come in view. I don't do it for other aneurysms, but for MCAs, I typically do it. So just keep in mind. I don't know if it's necessarily needed, but I kind of started doing it a while ago, and I still continue. This is another important thing that I look at when I'm thinking about supraorbital for an MCA. I look at where it is in relation to the sphenoid wing. So this is one of the earlier ones that I showed you, long segment MCA or M1, and I decided small aneurysm. So I thought, okay, this is small, manageable. We're going to do clipping. It's not an endovascular case. So let's do it. So when we get to it, to the aneurysm, here, I showed a little part of that video earlier. So we get to the aneurysm, the vein, the temporal lobe, it's all hanging in the view. And I just didn't have, I could pull the aneurysm in the view, but I just didn't have like a persistent view of the aneurysm for clipping. So at that point, I thought, okay, what about if I just dissect or remove this part of the sphenoid wing? So I coagulated some of the dura, removed the dura, or pulled the dura down. And then once I was able to resect that part of the sphenoid wing, I placed a retractor on the temporal lobe, and all of a sudden the aneurysm and the temporal M2 delivered in the view. And after that, the rest of the clipping became very easy. So that's one trick that I learned along the way, and that was kind of the basis of our cadaver study, which is, again, like I said, still in progress, and hopefully we'll have results available or published soon. This is another aneurysm. This was a large aneurysm, very complicated bifurcation. And here again, we found the aneurysm neck, which was wide and long, but there wasn't a good view, and I was not able to deliver the aneurysm into the view. So I did the same trick, coagulated the dura of the sphenoid wing, and then just used the same drill to drill out. And it's actually very safe drilling here because, remember, there's dura on the other side also protecting you. So as long as you know what you're drilling and you know your anatomy, it's actually very safe. and now doing a lot of cadaver dissection, if you continue doing the same maneuver medially, you can actually get to the base of the clinoid very easily and have a good anatomic view of the base of the clinoid. So we do that, then we cut out the dura, and then you all of a sudden start seeing more of that temporal lobe, and then you can use a small retractor for that last part, and then place a clip. So here in this case, I'm moving the video forward fast so we can finish that. I placed a clip. I was not very happy. Well, I mean, it's pretty typical for large aneurysm. I place one clip, then I place a second one, remove the first one, and then sequentially do that until you get the complete closure. Here's the video. You place one clip, you remove the first one, and then you can sequentially keep on doing that. I don't have the full video just in the interest of time, but you can do that to get a closure of the aneurysm. These complex ones, sometimes I do tend to end up leaving a bulbous or a rather generous bifurcation, because if you try to clip it too close to the M2s, you invariably end up compromising the M2s. Here's another cadaver model where we dissected, and we actually, in this model, we found a small aneurysm in the M1 segment, which is kind of a unique thing. But you can see that with this supraorbital approach, you can dissect a fairly good length. And then notice that temporal vein that we encounter in a pterional craniotomy is way over in the end of the spectrum or the view. So it's really when you approach the aneurysms through this approach, it's really not in your way. This is another one with slightly longer segment. And again, I will quickly go through that video. Sorry. All right, here. So let me go out. So you see the aneurysm. You know, this is a great view. I personally don't think that I need anything more than that. We had an anterior temporal around the neck, so I placed a small piece of gel foam to separate that from the clipping area. I placed my first clip. A lot of times, first clip is my pilot clip. I look at it. I see that I've incorporated the temporal M2. I have a lot of room to do any kind of maneuvers. So I thought that this was not a good clip. So I opened it. Here you can see now more clearly that the contralateral M2 is incorporated. So I go back again. Here in this picture, I'm going to stop quickly here. That little vessel down here is the anterior temporal. So I use my sucker to push it away from me, and then place the clip somewhat more. Here's my sucker. You can see I push that anterior temporal artery away. On the proximal side, the gel foam is keeping it away. And then I place the clip, and now I can see I like this configuration. The M2 is open. Both M2s are open, and we have So this is a post-operative view, complete occlusion of the aneurysm. So sometimes, a lot of the down pointing ones, you have aneurysm dome stuck. So here is again the same trick. Once I release the CSF, do a little bit of sylvian dissection, then I cut that dura again at the end. Start opening the sylvian fissure. Not a different instrument you can use. Nowadays, I just use an 11 blade. I would say that most of the instruments that we have are not truly designed for supraorbital. I hope that at some point we can evolve into that, but at the moment we don't have that. But most of the instruments we have are pretty good. They're not 100% great, but they're pretty good. So again, in this one, the aneurysm was down pointing, so I ended up coagulating the dura, drilling the sphenoid wing, and then dissect the M1, find the M1. Now we have good proximal control. A lot of these M2s were loopy vessels. Now we can see, once we have a retractor on the temporal lobe, the aneurysm starts delivering itself. And now you can see both M1, M2, both M2s, the aneurysm dome. This aneurysm had a small bleb that I wanted to incorporate, but it was difficult through this approach. So I ended up clipping the main dome with one clip, and then placed there's a small little nub of aneurysm left, which I then used a second straight clip to occlude. And I don't know if I have a post-operative scan on this or angiogram on this, but let me check. Yeah, I don't think I have the post-op angio on this, but it was complete occlusion. Here, just one last video, I hope, is aneurysm that was previously treated with web device. This individual, this was ruptured originally. We treated with web. Then about a year later, follow-up angiogram showed web compaction, regrowth of the aneurysm. So, I tend to prefer web treatments now because you can actually clip them later. When you coil the aneurysms, it's hard to clip because the clips don't really collapse the coil mass, but they can collapse the aneurysm mass. The web mass very well. So I'm going to quickly skip through the video, but look at the dissection is just pleasant. I have a lot of time now. When you do the web, post-web clipping, there is a lot of adhesions. There is some inflammatory process that's happening around that aneurysm. So you can see that there are a lot of adhesions, but we have a lot of time. This is M1. We have a lot of time. We have a lot of exposure because we're not doing any of that, temporalis dissection. We're not doing any craniotomy. We're not flattening the sphenoid wing. So all of that time is spent in actual micro dissection. And you can spend separating a vein from the aneurysm. And then I'll quickly go over then the M2, which was stuck, and I have a lot of time to dissect. So I spent all that time. And then I ended up placing in this one multiple clips to collapse the dome of the aneurysm and get a complete occlusion. And you can see the M1, both M2s patent, and then there is an artery coming immediately off the M2, which is also patent, and the entire vasculature is preserved. Of course, no deficits afterwards. You can see both proximal and distal vessels and have a lot of view. Here, one last picture actually, or one last video. This was a ruptured aneurysm that presented late, and we decided to clip this. So this is I don't have an angiogram video, but very complicated aneurysm, as you can see, kind of a cauliflower-like involving the M2s. I thought this was, M2 length was okay. I thought this was a good aneurysm for supraorbital, but complex. So again, cerebral fissure dissection. Here, again, like I said, I used many different type of instruments. Here, we used a small TB needle to start the dissection. But look at how pleasant the dissection is in this area. No veins in my way. As I cut the adhesions, all of a sudden the M1 and the bifurcation becomes visible. Remember, I've done the basilar cistern dissection already. So M1, we have good proximal control. This is a complex aneurysm, so I wanted proximal control early. Then I go to the aneurysm. Once we do that, go to the aneurysm, and I start, because this is post-bleed, there are small vessels on the dome of the aneurysm, so I'm dissecting that. This is the frontal M2. I don't have a good view of the temporal M2, but I have a lot of room. So here the vein was stuck to the aneurysm. I didn't dissect it too much in the beginning, but once I open up some of these Sylvian fissure, I can actually see the temporal M2. Then I place a temporary clip. And because of the complexity of this aneurysm, I thought I still didn't have a clear idea of what my clipping strategy would be. But with the temporary clip, I'm separating that from the inferior part of that cauliflower dome from the temporal lobe, pulling the aneurysm into the view. And now I have a M1, both M2s. Here is the temporal M2, the yellow looking one with hemosiderin staining. This is the temporal M2. So I have a clear view. I don't have a great view of the aneurysm, but I don't need the great view of the aneurysm. I don't need to see the whole aneurysm. I just need the neck. So I get a lot of dissection around that area just so that we have mobility. I use some bipolaring to shrink the aneurysm, especially around the neck area. And then just these complex aneurysms, I start off with a pilot clip. I placed my pilot clip. This is not the last clip here or the final clip here. This is just to collapse the dome, just to get the aneurysm to pull into the view. And so I do that, then that gives me more opportunity to dissect more aggressively the domes. Then I place a second clip and collapse the aneurysm, remove my first clip. And a lot of times when I do that, the second clip actually pulls back. So I do that a few times. And as I keep going, advancing, it is like what I like to call walking on the aneurysm. As I do that, I can then continue to expose more of the proximal part to get a better understanding of what the final clip strategy or clip configuration would be. So I do that, and then I find that, okay, most of the aneurysm, the two domes are clipped, but the inferior dome of that cauliflower was not was not clipped with that last aneurysm. But I thought that if I try to incorporate that, I will end up damaging or incorporating or compromising the M2s. So I dissected completely, used that opportunity. Now the temporary clip is off. I have a lot of adhesions here. So I dissected completely, and then it becomes more evident that I can just put a separate clip on this separate dome and get complete closure. And here I readjust my clip for the main part of the aneurysm, and then remove the first clip, find that dome, expose that dome a little bit more. Still not very happy with the overall look. But just to show you, you have so much time and so much maneuvering. But now I'm pretty happy that I have separated that inferior dome as a separate entity. And once I do that, then I can put a separate straight clip on that inferior part of the dome and include that. I don't have a postoperative angiogram. I have a postoperative CT angio that showed complete occlusion, and then intraoperative examination as well. Patient, of course, woke up with no deficits and made a great recovery. So why do we do this? We do this because of cosmesis. So that's the most important thing. Here is a patient that we operated, and this is a 6-month follow-up view. You can hardly tell which side the original. Actually, this is a 6-week follow-up. You can hardly tell which side was the surgery, but then when you ask them to actually raise the eyebrows and show you the incision, then you can actually see it. At 6 months, I don't have a 6-month picture, but at 6 months, you couldn't actually even see. Here's another picture of a patient that we treated. Honestly, I can't even tell which side was the surgery unless I either ask the patient to look in the chart, raise the eyebrows, maybe a little bit of acceptable asymmetry, but to be honest, I still can't tell which side was the surgery. I'm assuming it was the left side, but still pretty good result. So the lessons learned through this journey of several years, neurosurgery is a lifelong learning process, and learning is a team sport. There are a lot of people who have helped me during this journey and continue to help me, who are, most of those are my mentors, my friends, my colleagues, people I talk to in meetings, and very importantly, my trainees and medical students who are interested and want to push the envelope of neurosurgery. I also want to leave with this one final thought. Competition is evolving, endovascular approaches. There are new devices coming out, such as intrasaccular devices, which continue to reduce the surgical experience that we get. But at the same time, we as cerebrovascular neurosurgeons have to evolve, because if we don't evolve, we will become history. So with that, I would end my talk, and I would like to thank you, some of my colleagues, mentors. Mike Ortiz, one of our graduates, Ravi Nuna, one of our graduates, Dr. Asif Bashir, who's one of my colleagues that I've done a lot of this work with, and thoughts and ideas and exchange. Some of our research fellows, Ibrahim, who has done a fantastic job at a lot of research projects. And then not to forget some of our excellent medical students, Sabrina, Genovese, and Hunter Brooks. All of these people have helped me through this journey of research, innovation, and continued learning. Thank you.
Okay, Dr. Siddiq, excellent, great videos. I'm not a neurosurgeon, but I know it was a high quality presentation. And one of the ideas, let me just say a word about the platform, because while you were speaking, I just put into the platform of AI, tell me about Dr. Siddiq. Wow, it gave me such a summary of what you've done, what likes you have. Do you see it in the panel there, the AI description of your career? I mean, it's amazing. Just in the side panel, you can put, please tell me about Dr. Siddiq's career. And and you have a big interest in videos, it says. Video-based learning, video-based education, right?
Yeah.
Yeah, it said a lot about you. And it gave me some ideas, because as we mentioned at the beginning of your presentation, you also speak Urdu and Hindi, and may be interested in televising in those communities. I thought, and by the way, Dr. Lanzino came by.
I saw that. Yeah.
Yeah, he's He's
Yeah, he's a great mentor. He's a big name in cerebrovascular neurosurgery.
yeah. I was thinking maybe, well, like either put you two guys together and do maybe a series.
Yeah, I think that would be a great idea.
Yeah,
He's phenomenal.
I'll ask him. I love working with him. He's done a lot of webcasts with us. He's getting
Yes.
quiet now. I don't know what's going on, but hopefully he'll be ready to go again because we did quite a few before.
Yeah.
So as well as I'll let you express the willingness to televise if you want to televise in cerebral vascular or whatever to the Urdu or Hindi community, we'd love to open that up.
Yeah.
We
Yeah.
would love to.
I think either the same talk or some reiteration of the same talk. I think I can certainly do in Urdu. I wanted to do this was my first one here on your forum, so I wanted to have it available for our audience, our residents. Some of them medical students I see have joined in, Marcus and Hunter and Ibrahim, and some of the residents I know are listening in the other room on that forum. So I
Well,
think,
they will get involved, but they may be shy a little bit at first,
yeah,
you
of course.
know, but they'll get over it.
Yeah.
Uh,
So I think,
Go
yeah, I
ahead.
think we could do a reiteration of this in Urdu. Urdu and Hindi are very similar languages, so most people who speak Hindi or Urdu can understand. I speak kind of the Urdu version of the similar language. So I think that would be a good idea. We can approach some of the communities in those regions in the Southeast Asia. We also talked about televising one of our symposiums that we may end up doing in April. I think you and I should communicate about that and see how we can make that work.
Well, this is great to meet a video lover for education because
Yeah,
that's what I do all day, and
yeah,
I love it too. You're going to see it expanding in all areas, in most languages. Hopefully, we'll get some going in French,
yeah,
more in Spanish, and more in Portuguese
yeah,
and Russian. We've done a few Russian.
yeah,
But we like to go all over the world.
yeah,
Uh, Various countries are kind of shy, timid. They're not used to using videos as education, as you probably know.
yeah,
But one thing, Pakistan loves to use video. That's one thing I've noticed,
yeah,
and
yeah,
you probably noticed that too. They
yeah.
do a lot of work on Zoom.
Yeah, 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 they do. They do. So Spanish reminds me, one of my trainee was an excellent surgeon himself, and I've done a lot of this work with him. Maybe if you're interested, I can ask him to do this same version, and then maybe add some of his own stuff into it, and present in Spanish for the South American community.
No, you can believe me. This station is yours. You have an idea, we'll do it. Do it,
Great,
So,
great. I love it.
yeah, I love it too because I mean, quality education like we just did can't get enough. You can't
Yeah,
get enough.
yeah,
So I love to televise whatever you want to televise, whatever you think is useful for the surgical community. I would love to televise it. We
yeah,
have lots of space, lots of time,
yeah. Good.
and yeah. I've loved it from the first time I saw it because I go way back to Google Hangouts. I don't know if you were in that era of televising, but Google had a platform called Hangouts, the
Yeah,
predecessor.
yeah.
Remember them? The predecessor
Yeah,
to
I
Zoom.
remember. I didn't use it as much, but I do remember. Yes.
Yeah, but Zoom is so much better. When that came on the market, wow.
Yeah.
And then the pandemic hit. I mean,
Yeah.
what a bonus for that business, for the pandemic. Well, I know you're busy, so we'll keep in touch and any ideas you have, let me
Yeah.
know and we'll
Yeah.
communicate about it.
Yeah.
And anybody in your team
Yeah.
that wants to present, let me know.
Yeah.
This platform is for education.
Yeah.
So any ideas you have, we'll listen
Great.
to.
Great. Do you I was going to say, oh yeah, can you send me your email also? I don't use LinkedIn very frequently. This just came across and I was like, oh, great. This is perfect opportunity.
Yeah,
But
yeah, I'll
send
send you
me an
my
email
email.
also. So I have your, I think we did communicate a while ago, maybe several years ago through another individual who was also interested in a lot of telemedicine. His name is Dr. Tahir, Farhan Tahir. He introduced us a long time ago, but it didn't
Oh,
really
okay,
materialize.
okay.
So
Well,
yeah, send me
it's good to hook up to you now,
yeah,
and
send
look
me an
forward.
email, and then we will continue to do this work. I love it. This is great.
Okay, then you
And
have a
I've
good
seen a
night.
lot of your videos also, and to be honest,
I'm sorry.
sometimes I've seen a lot of these videos, and to be honest, sometimes if I'm doing some surgery, I like to see a lot of videos beforehand to prepare myself. In
Oh,
my
before
earlier
surgery, you do
career,
that as a.
I thought this was a great opportunity, and even now I encourage my trainees to find all resources, especially the videos, because they really give you you can we can back in the day we used to read a lot of books, but for surgery it's so important to actually see what we're talking about, because the color, the picture, the two-dimensional picture on a book does not translate as well as an actual surgical experience.
As a
The video.
a text description.
Yes.
Video is much better.
Yeah.
Well, yeah, that's good. Do you find a lot of surgeons, neurosurgeons do that? They kind of prepare before surgery. Is that changing the way that some surgeons prepare? They use virtual reality or just watching YouTube videos, or
Yeah.
what do you find?
Yeah, many different things, but I think YouTube video has really, at least for me, and of course, my colleagues, and has really opened up a lot of this world, and that's why I want to contribute more and more to this myself, because I
Okay,
benefit from it on the other end.
right.
Yeah.
So the neurosurgery community likes YouTube videos.
Yes.
Well, that's good to hear. You learn something every day.
Yeah.
Okay, then. You have a
All
good
right.
night.
Thank you. You too.
Thank you.
Bye.
Thanks everybody for coming. Bye.
Bye.
Let me see here.